everybody. Thank you so much for inviting me and having me present today. I think one thing I forgot to put in my little intro bio that I sent in was that I also do a lot of outreach and advocacy work to try to make sure that all the health professionals know we exist. When I started my position a couple years ago, I realized that no one knew that our company or our program was a thing, and all the good work we've been doing. So we will spend a lot of time today talking about monitoring programs in general and ours in particular. And at the end, we'll go through a few case examples to sort of illustrate the variety of things that we can help with and that we do, and how you could appropriately respond when you run into situations at work with different types of scenarios that are pretty common. So let's go ahead and get started. Obviously, every lecture has some objectives. We'll talk about health professional addiction. I'm going to make an argument that health professionals are a special population, just like other special populations in addiction, such as adolescents, pregnant women, etc. We're a special population too. We'll talk about professional health programs in general and ours in particular, and the services that we all offer. But we will hopefully understand some common workplace scenarios and how to appropriately respond. All right, so health professional addiction. I'm sure we could all sit here and list off a lot of who is a healthcare professional, but any physician, physician assistant, pharmacist, dentist, nurses, nurse practitioners, certified nurse anesthetists, EMTs, basically anyone working in the health professions. We all have we're pretty much like the rest of the population when it comes to our lifetime prevalence of substance use disorder. Somewhere on the order of 15 to 20% of physicians and other health professionals will have an addiction at some point during their lifetime, or rather they'll meet criteria for it. And these do tend to co-occur with other mental health issues, depression, anxiety, especially with the increase in workplace burnout. We're seeing more burnout as a co-occurring condition of substance use disorder. The most common addictions that we see are the same things that we see in the general population. We see a lot of alcohol. Historically, our programs were seeing a lot of opioids, specifically through diversion of medications. That is coming down now that the regulatory environment has become so much more strict. And we're starting to see more THC, actual substance use disorder, cannabis use disorder around THC. So, as I mentioned before, I would argue that health professionals are a special population when we think about substance use disorder and the other mental health conditions. Our work focuses primarily historically on substance use disorder, but health professionals are a special population for all mental health conditions, right? We, just like the other groups that are considered special populations, health professionals do benefit from having specific treatment programs for their group. You know, we have our own set of oddities that make it important for us to be cohorted with other health professionals. So if you think about this gentleman in the middle in the long white coat, let's say he has an alcohol use disorder. He is highly educated, obviously very intelligent, and has a higher socioeconomic status than the majority of people that you'd find in sort of your run-of-the-mill substance use treatment program. He's also very accustomed to being in charge, and maybe will have a challenging time listening to his treatment team when they are telling him the plan for helping him get better. Many of the people who come in having had a DUI or having been referred by their employers, they might be pre-contemplative. They don't even see that they have a problem yet, or they might even be mandated to care. And so this highly intelligent, moneyed, in charge individual doesn't even think he has a problem, and here he is being told he has to go to treatment. He's going to be very challenging for your standard treatment team, say at your local facility. He also has concerns that other people don't have, right? He's worried about his medical license. He's worried about any legal ramifications. What if maybe he's been making little errors or charting wrong, or he's not been his normal meticulous self. So he's worried about legal issues and obviously worried about his professional reputation. What if somebody found out that he had to go to treatment when he doesn't even identify as having a substance use disorder? So health professionals are fairly unique, and because of that, we have a whole system of care in place to help health professionals when they do develop issues. And that system is led by the PHPs. So PHPs go by a whole bunch of different names. Ours is a wellness program, a health professional wellness program. We used to be called the Monitored Treatment Program. Around the country, you'll see physician health program, professional health program, professional wellness program, all sorts of names. But basically what we all do is provide services to ensure that providers or practitioners are safe to practice and to assist them in either obtaining or keeping their professional license. So it's a little abstract, and we'll dig more into what all of that means. But essentially, we are oversight organizations to help professionals get that specialized care that they need in order to get back to work. And the main thing that we help with is substance use disorder. In the last 5 or 10 years, there has been more movement to help people with primary mental health issues, depression, anxiety, PTSD, burnout, and we're seeing more and more physical issues as well. We're with sort of the aging population, we're seeing people working later into their senior years, getting more motor disorders, tremors, etc., as well as some dementia cases, as people are working really late into their lives. Nearly every state in the country has a PHP or a cooperative agreement with a state who does. So if you ever leave New Mexico, this is still a service that's available to you wherever you land. But don't leave New Mexico. We can't afford to lose any health professionals. All right, so a little bit about us. The New Mexico Health Professional Wellness Program is a completely independent entity. We're a 501c3 nonprofit, and we've been around since the 80s. It's been through many iterations, many different organizational structures. Our current form is the strongest it's ever been as a 501c3 with a board of directors. We do adhere to very strict confidentiality measures, HIPAA, 42 CFR, which is the substance use disorder regulations. And we work with multiple health professional boards. So we'll talk more about which boards we do and do not work with. But basically, if a person has a health professional's license, we're a good starting place, and we'll probably be the one that you need to talk to. So we work under contract with most of the boards, which means that part of your licensing fee that you pay when you do your license initially or your renewal goes to us. And that means that our services are free or almost free to people who are licensed. And what we do, as I've mentioned before, is we're not really a treatment provider, we're more of an oversight agency. So we call it monitoring, and we'll talk more about that. But I'm not going to be the one prescribing any medications for you or sitting down and coming up with like a complicated new diagnosis and sending you off for blood work. What I'll do is get reports from your doctor who's doing that and make sure that you're staying in compliance with the treatment plan that we've put forward. As you might have gathered, we have sort of a push-pull in our dual mission. So PHPs have 2 different missions that we're trying to balance at all times. We're trying to provide a public service by protecting people from impaired professionals. So we don't, we want to make sure that we're detecting and redirecting people who might be impaired at work. So anybody who's showing up drunk or high at work, anyone who's so depressed or so anxious that they can't actually do their job, anyone who's so tremulous that they should not be operating, we're trying to protect the public from folks who should not be practicing. But we also are advocating for people to return to work or to continue working if they are under control with their condition, if they are safe. And so it's this dynamic for us at all times. And and it sometimes creates some tensions here and there because, you know, our view might differ from both the licensing board or the participants' view about whether someone's safe to practice. And so we have to sort of navigate these muddy waters. So I threw out this word impairment, and I think everyone has sort of an intuitive understanding of what impairment means, but I like to be really clear with it. So as we all know, a person can have a disease, right, and not really be impaired by it. A person might meet criteria for diabetes, but not have any sort of secondary effects from their diabetes. When we think about mental health disorders or we think about substance use disorders, a person can have a mild alcohol use disorder. You know, you go through the DSM-5 criteria and maybe they have 2 or 3 of the criteria met. It just hasn't gone to the point yet where it's starting to really impact their life in multiple domains. However, impairment is when the disease has reached a point where the person can't perform specific activities. And when we think about physicians or we think about health professionals, that's the practice of medicine, right? So the American Medical Association has put out a definition of physician impairment that we use more broadly for all of our health professionals, which is the inability to practice medicine with reasonable skill and safety. And that can be due to mental illness, physical illness, or excessive use of drugs or alcohol. So I put the picture of the Titanic in here because I feel like it's a pretty good analogy. There's this idea, right, that maybe it's an urban myth, I'm not sure, that the bulkheads on the Titanic were built incorrectly. So the bulkheads went something like 75% of the way up the ship, but not all the way through the vertical aspect of the ship. So it wasn't a problem until there was a hull breach, and then the water was able to sort of fill each of the compartments of the ship because they weren't isolated from each other. So substance use disorder is kind of like that, right? Like we all have weaknesses in our hulls and our ability to manage different stressors. And substance use disorder is a progressive disease, sort of like water filling up those different chambers of the ship. So you might, depending on how good your internal construction is, will be how long it takes to progress or how long it takes for your ship to sink. So often we'll see untreated or undertreated substance use disorder that is gradually progressing. And for some people, it's really quick. For some people, it's really slow. But we all have some internal structural milieu that can become damaged. And over time, it makes us impaired. We can't float anymore. We can't make it through the tasks that we have to do and that we have to do exceedingly well. So for health professionals, the real reason that we are sort of a special population is our job is safety sensitive. So safety sensitive jobs, this idea came around a long time ago and really was about like pilots and long distance truckers and railroad workers, but it also applies to us, right? If we make an error at work, we can cause serious injury or death to our patients or even to ourselves or our colleagues. We have cognitive errors that we might make. Maybe we miss or we make an incorrect diagnosis. We're not paying attention and miss something. There can be motor errors. You know, you're intoxicated or you've got a motor illness and you just plain mess up with a motor skill that is very fine work. Medication errors are very common. So wrong name, wrong drug, wrong dose, wrong concentration. So many issues can happen with medications. We also work with hazardous materials, radioactive materials, biohazardous material, infectious materials. There's procedural errors, there's misreads on EKG, all sorts of safety sensitive issues. Hey, somebody has a chat. Let's see what they say. Okay, so this person put it to everybody. So she says, this is assuming the person is aware of these impairments and seek assistance. What happens when they don't? And does your organization advocate for others around them to bring this to their and or your organization's attention? So we'll go through a couple of cases during the cases at the end where we talk about a few different types of scenarios. The majority of folks that we see are not self-aware, at least at first. We often have folks being referred to us by employers, by their licensing boards, even by colleagues, to come and get an assessment by us. Sometimes we do have the more insightful folks who have recognized that maybe they're having an issue, and they have two things. They have insight and they know we exist. So it's unusual for people to have both of those. So yes, you're absolutely right. Seeking assistance is one of the biggest barriers, and having that insight that they are aware of being impaired. All right. So as I was saying, safety sensitive jobs, we have to make sure people are safe. So what do PHPs do? So we sort of have four main domains of activities. We assess for when we feel like there's potentially impairing conditions, however those referrals are coming in. We engage people with potentially impairing conditions in the monitoring contract, which I'll walk us all through. We do a lot of advocacy and collaboration, and then we also serve as a referral source, and I'll talk through all of that in the next few slides. So the vast majority of my, maybe not the vast, the majority of my time is spent doing assessments. So assessments come to us after some sort of referral, and it could be a self-referral, someone who's identified that maybe they're worried about themselves in some way, or their partner or spouse is worried about them, their employer's worried about them. We do still get most of our referrals from the licensing boards, which is something we're trying to change, which is part of the whole outreach and community awareness campaign that we're working on right now. But most of our referrals have been historically from the licensing boards. And they historically have been for things like DUI arrests, other substance-related arrests, complaints from the employer or anonymous complaints submitted to the board. And then folks have to come to us to get an assessment done. The main things that go into the assessment are the interview and the collateral. So I spend an hour or two with every single person who's sent to us, interviewing them about what happened to bring them to our attention, their substance use or mental health, or whatever their primary issue is. We spend a lot of time asking about workplace behaviors, workplace impairment conditions. We'll talk about mental health history and treatment episodes. We'll talk about physical health issues, family history. It's a very comprehensive interview. But then I still have to make sure that what I'm hearing is actually true. So there's a lot of collateral collection as part of these interviews. I'll read the arrest reports or court documents if those exist. I'll talk to people at work. I'll talk to spouses. We often, nearly always, do drug testing as part of our assessment process, because if someone's saying, oh, I haven't had a drink of alcohol in the last 6 months, we need to verify that they are at least not currently intoxicated or haven't been in the last 3 days by doing a drug test. So we do collect a lot of collateral information, and then based on all of that, we make recommendations. And depending on where the person came from, whether they're self-referred, board referred, etc., will dictate who sees the recommendations. If the board refers a person, then the board gets the recommendation letter, but a self-referral, it just goes to the person who came in. And the recommendations tend to be one of three things. The recommendation could be, take no action, you're okay, there's no need for monitoring. Option 2 is, I'm not really sure. We're going to keep an eye on you for a 12-month contract and see what happens in the next year. Maybe the disease is progressing. Maybe we need to just take a break and see how if a person can stay abstinent for 12 months, that usually is a very good sign. Or option 3 is, oh yeah, this person definitely has a problem. We're going to engage them in a full contract and do our full monitoring agreement with them. So what is monitoring? Monitoring comes in a few flavors. The main flavors are voluntary or mandatory. So volunteer is folks who are self-referred. Some of our employer-referred folks can stay as volunteers. Mandatory is the board knows about you and the board sent you to us. The other flavors obviously are substance use, mental health, and physical health. So all of these have sort of different monitoring components. But still, the majority of our participants have historically been substance use, so we'll talk most about that. Our main goal is to get somebody to the point where they are safe to practice if they're not, and then to collect monthly paperwork to make sure that they're continuing to be safe to practice, right? So we get drug testing done. It's a random sort of app-driven system where you check in on your phone and it tells a person if today's a testing day or not. We collect a monthly report from a worksite monitor who's usually a supervisor or at least someone at your same level if you're in a group practice setting. Often we require either a counseling or a psychiatry component, or in a physical case, maybe you need to stay connected to your neurologist or your sleep pathologist, somebody like that. And then sometimes there's support group requirements. Often with our substance use patients, we have a variety of different support groups that they're required to engage with. Regardless of the type of contract, whether it's volunteer, mandatory, substance use, mental health, etc., all of our contracts do require abstinence from all substances, including alcohol and THC, now that that's legal. And the reason for that is we can't tell the difference between the person who drinks a glass of wine once a week with dinner and the person who's got their escalating alcohol use pattern based on drug testing, et cetera. We just can't tell. And especially for our substance use folks and our mental health contract folks, any amount of substance use is not going to help them get to a more stable state. So all of our participants do sign a contract agreeing to abstain from all substances. And then our substance use disorder contracts are 5 years, and that's the national standard. Some states go a little shorter with a 3-year contract. Some do 10 years. Some it's a lifetime contract or a until you retire contract. But we start in New Mexico with a 5-year contract. The next thing that we do, or that I do quite a lot of, is exit interviews. So these are the folks finishing their contracts, making sure that they are indeed compliant, have been compliant, and then I recommend that they get released when their contract is over. It's the most fun part of my job. I really love talking to people on this end of their time with us, because often they have the insight that they didn't have before, and they're able to look back over the time that they were with us and be really grateful for the changes that they've made in their life and how many positive things they've seen in their years of time with us. And it makes up for some of the folks who come in who are in that pre-contemplative or mandated state and are pretty unhappy at the beginning end of their contract. As I've mentioned, I do a lot of advocacy, and I'm doing more and more outreach. So advocacy historically has come in the form of us providing reassurance to employers, to licensing boards, to medical schools, GME programs, et cetera. Just basically saying, this person does have a disease. They have alcohol use disorder. They have major depressive disorder, but they're okay. You can hire them. They're going to be great, and we'll keep a close eye on them to make sure that if anything happens, we'll find it early before any bad patient outcomes happen. And then the outreach piece of going to the medical schools, going to the GME programs, talking at venues like this, just to make sure that everybody knows we exist and that we have services available. So quick summary, what we do and what we don't do at Health Professional Wellness Program. So we do referrals. So like I said, we're not a treatment program. We have a list of programs that we have worked with in the past that provide excellent care to health professionals. We have lists of local therapists and psychiatrists and medical professionals who are used to working with health professionals, so that you're able to get that sort of special population care that you need. And we do run some professional groups around the state for our substance use patients or substance use participants who are able to meet once a week with other health professionals who are in our program and work through things together and create mentorship bonds over the years of that 5-year contract. It's really helpful to have our people in years 4 and 5 sort of create a safety net around our people just coming in and maybe in their first year of monitoring to help them learn the ropes. As I mentioned, we do monitoring. We do a lot of advocacy. What we don't do is treatment. We don't keep a list of attorneys. Sometimes folks will call us and be like, I need a good healthcare attorney. That's not us. I have no idea who the good ones are and who the bad ones are. Obviously, we don't give legal advice. Sometimes we'll encourage people to read what they signed when it comes to their licensing contract, their licensing application. A lot of problems can be resolved if you read the fine print. And we also don't directly do any license actions. So we're not the medical board. We're not the pharmacy board. We are an independent nonprofit organization. What we do is make recommendations about a fitness for duty. So this person's safe to practice, this person's not safe to practice. And when the board is involved, that can result in licensure action. But I'm never going to write to the board and say, oh, this person's license needs to be inactivated. All I say is, I don't think this person's safe to practice. It would probably be good if they took some time off to go get treatment. Which is, it's an interesting relationship, and it gets back to that dual mission, right, of public safety versus providing care for professionals who need it. So a lot of people wonder if all of this is worth it. You know, it's signing a 5-year contract seems like an awful lot, and it seems like a lot to do the worksite monitoring and the drug testing, et cetera. So the question arises of like, does this work? And the answer seems to be yes. There's not a ton of research because there's only something like 47 PHPs around the country, and most of us are pretty small. But the research that does come out has shown pretty conclusively that the PHP model is the most effective model of care for substance use disorder. They have looked at folks, this is just one of the more recent ones, it's open access, just came out about 1.5 years ago. And what they did was they called folks 5 to 10 years after finishing their contract. So these were people who did a 5-year contract, had 5 years of no monitoring, and then were on sort of the eligible to be called list. And what they found was that these health professionals, most of them are physicians, 97% were still in recovery. And that's sort of an unheard of treatment success rate in the substance use world. Substance use relapse rates, vary from 50 to 70% for the average treatment facility. And we're seeing, 97% success rates potentially. Other studies have had numbers as low as 80% success rates, which is still phenomenal when it comes to substance use care. So yes, it's intensive. Yes, it's very long. Yes, there are a lot of components to it, but people who engage in the PHP model do achieve remission of their substance use disorder, which is part of why I love my job. I get to see these success cases. When I was in residency and fellowship, it was the revolving relapse door that I was seeing, and I love not having to welcome people back too many times to the PHP. So we're going to segue now. Actually, let's take a little pause. Does anyone have any questions before we go into our case studies? I'll give you 15 seconds to type because I know sometimes you're like me and don't actually know how, and they're just pecking. Okay, seems like no burning questions. So we're going to segue next into our case studies. These are some of the more common things that I'm seeing recently. Obviously, if you want to put another scenario into the chat, I'm happy to talk about that too. We get a fair number of, oh, I have a friend who fill in the blank, and I'm happy to run through those scenarios too. But these are the most common ones. The DUI arrest. This is by far the most common thing that we see. And the DUI arrest is unfortunately common among New Mexicans and among the health professionals of New Mexico as well. So in this case, we'll say that this is a resident who has their first 2-day weekend in, it seems like forever. It's been 6 weeks or more since they had 2 days off in a row. They go out on a Friday night and overdo it at the winery or the bar or the brewery. They don't really think much about it and decide to drive home, get pulled over at a checkpoint. They weren't speeding. They didn't do anything. No one was harmed. They're going to hire a lawyer and they expect all of this to go away. But the licensing board disagrees. The licensing board doesn't care if you think this arrest is going to go away. What it says in the agreement that everybody signed when they got their license or their training license is that you have 30 days to report to the medical board. So this individual didn't do that. They did not report to the medical board because they were going to get a lawyer, and sure enough, the case was dismissed. The arresting officer didn't show up to court, so the case was dismissed. It's now been 2.5 years since the arrest, and this person is applying for their full independent license, and the arrest pops up on their license application. Yes, the board is running those background checks, and it's still going to show up on the background check. So this individual did not disclose it, and it was discovered on their license renewal or their independent license application. And now they have to come see me. The board is not happy because they failed to disclose it. But basically this person messed up, right? Like they messed up by drunk driving, and then they messed up by not reporting it. Oh, somebody's microphone just turned off. Min and Cynthia, do you have a question? Or maybe am I just hallucinating? I'm just hallucinating. Never mind, guys. Okay. Things are just rearranging. So take-home messages from the DUI arrest are, you do need to contact your licensing board and your employer immediately within 30 days after any substance-involved arrest. Don't wait until your license renewal. Don't wait until a court decision. The way it's worded is you need to take care of this during that or immediately following the arrest phase. The board is also going to send you to us for an evaluation. So if they are going to do that, you might as well get ahead and just contact us ahead of time. That'll make things go faster. We'll get through the process more smoothly and quickly. Obviously, if we're recommending any sort of treatment, you'll need to follow that in order to get back to work and keep your license active. Case 2. So this is concern for a colleague. So I think that the person who asked a question earlier was sort of alluding to this lack of insight that a lot of people have. So often we can see it in others before they see it themselves. So this person, emergency medicine physician showing up, they used to be very on time. Now they're sort of rolling in 10, 15 minutes late regularly, look kind of disheveled. Sometimes they smell a little funny, but they're never actively intoxicated as far as you can tell. It's a hard scenario because it's really uncomfortable to walk up to someone and be like, hey, I notice you're late and you smell bad. Are you okay? Are you drinking? What's going on? But that's exactly what we need to do, right? Like we need to take care of each other. We need to express concern for each other, especially in these safety sensitive roles. We need to be okay with a low level of confrontation where we're able to say, I'm worried, I want to make sure that you're safe, and that everything's okay. So with this case, when you're concerned about someone else, if you're comfortable enough to do it, do the confrontation yourself. Do the concerned outreach to a friend or a colleague. If you're not able to, then talk to a supervisor, talk to a manager, talk to another person who is maybe just more willing to confront. I am not that confrontational. I've had to become much better at it, but it's really hard to confront a friend, and maybe there's, that person in your work group who's just that one with no filter, or who's from, the Northeast somewhere and is able to just say what they think. So you can have them do the conversation, but this person needs to hear it. And then what you need to do though is take it to that next step. Not just be like, hey, I'm concerned, or is there an issue, but what can I do to help? And the thing you can do to help is sit with them while they call us, sit with them while they email us, and then we can take it over from there. So HPWP, we get referrals like this, and sometimes it's just like, hey, my boss is worried about me. I don't think anything's wrong, but they asked me to sit down and email you, and then we do. We just sit and we have the conversation. We figure out what's going on, if anything's going on. Often it's things like divorces or having young children in the house, and like all these outside stressors that are just sort of leaking in around the edges to the workplace, and a person's not on their A game, but they don't actually have a substance use issue, or maybe they do, but it's very much in reaction to something going on in their life, and we're able to put them into one of those like 12-month let's keep an eye on you contracts to help them get the structures, get into counseling, get into like couples therapy, find better childcare situations, something to help take the stress off this individual. All right, so if it's off duty, talk to them, be a little confrontational, it's okay, or talk to a supervisor and let them do the confronting, and then do offer to help them contact HPWP. All right, next case, case 3. So now we've actually got somebody intoxicated at work. In this case, it's cannabis, because we're seeing more of that, but alcohol is probably the biggest one that we see people showing up to work drunk. We've had people show up in the operating room with BACs 2 and 3 times the legal limit. So knowing what to do when somebody's actively intoxicated is really important. And I don't think this is well covered in most medical or other training program curriculums. So in this case, I'm going to pick on emergency medicine again. We've got a guy who has a reputation as partying hard on his off hours. In general, it had never leaked over, as far as anyone knew, to work hours, but these days his scrubs smell a little bit funny from the cannabis. He'll leave on these short 10-minute breaks frequently and come back just looking a little glazed and way too relaxed given the chaos that's going on in the emergency room. And you are actually concerned that he's smoking marijuana, or in another scenario, drinking during shift. So the thing to do and to remember in this case is it's okay to stop the line. And I hope everyone here knows the phrase stop the line. It's from manufacturing, like heavy equipment manufacturing. And the idea is like, if something is wrong, stop the manufacturing equipment right away. Just stop that conveyor belt so that nothing else goes wrong. And in medicine, we need to do the same in all of our roles, whether it's an outpatient clinic, whether it's inpatient or surgical, procedural. Everyone on the team, from the scrub tech to the secretary, everybody needs to be able to stop the line when they're concerned for an intoxicated coworker. And the reason for that is we need to protect patients from imminent harm. The next thing after the line is stopped is for that person to go and get a for-cause drug test. So different workplaces will have different ways of managing this. It should be in every operations manual somewhere of how to deal with it. but basically they need to be breathalyzed and they need to pee in a cup right away to see whether anything's positive on that toxicology screen. And if it is, they need to go home and not return until they have contacted us. And typically the employer will also need to contact the licensing board. This is a breach of the Medical Practice Act, showing up to work intoxicated, and the employer is required to report that to the board. The next step, obviously, is going to be talking to us and getting care if needed, and then ultimately returning to work. But we need to make sure that this person's not going to show up intoxicated again. So let's see. Yep, got through all of it. So if you're concerned, use a stop the line approach. Some workplaces have a phrase. Where I trained at University of Iowa, we use stop the line, which is why it's stuck in my head. But if you trained somewhere with a different phrase, or your workplace has a different phrase, make sure you know it. The person needs to be taken off duty, the for-cause testing, reporting to the board, and then they should be encouraged to call us and the board right away to self-disclose. So some people are surprised about the cannabis thing. So I like to make sure that this is very clear. So cannabis is an impairing substance. So the National Safety Council, which is sort of this big safety organization that talks a lot about safety sensitive workers, they put out a position statement back in 2019, I know, 4 years ago, that states that cannabis impacts psychomotor skills and cognitive ability. That has not changed. Cannabis still impacts psychomotor skills and cognitive abilities, even though it's now legal in New Mexico. The NSC then went on to say there is no level of cannabis use that it's safe or acceptable for employees who work in safety sensitive positions. It's pretty black and white. A person cannot be intoxicated on cannabis while working. The question becomes, right, is using cannabis off hours. And a lot of people use alcohol off hours and don't have an alcohol use disorder. Some people use cannabis off hours, and that's okay. But cannabis has a really long period of elimination. And, you know, if you use with any regularity, it might last in your system weeks, sometimes a month or more. And we don't have any, so with alcohol, right, you can measure ethanol, like the breath ethanol test, or you can measure the longer acting biomarkers. You can measure ETG, ETS, PEth, that are those long biomarkers of alcohol use in the past. With THC, we don't have that yet. We only have the presence or absence of THC. And if a person has THC in their body, there's no way to know if that use was 10 minutes ago, 10 days ago, 10 hours ago, and whether or not they're acutely intoxicated. Like alcohol, we can tell if a person's had alcohol recently because we can do the breath ethanol test, we can do the urine ethanol test, we can do the blood ethanol test. We don't have that for THC. So because of this long period of elimination, say you're that person who is accused of being intoxicated at work, but you're not intoxicated at work, they do that for-cause drug test and it's positive for THC. And you're like, I have not used in 3 days. I used last Friday. Today is Monday. It is not the THC that's causing me to act weird today. You don't have a foot to stand on, right? You can't prove based on the urine test that that THC didn't happen 2 hours ago. So based on all of that, I recommend health professionals not use any amount of THC, because if there ever is a scenario where you get drug tested at work and it's positive, it's going to be very hard to defend when your use happened and that it wasn't impairing you at the time of an issue. Malpractice wise, this is definitely a significant concern. All right, let's see. Any questions? I always feel like I get questions after the cannabis stuff, so I'll pause for a moment. No? Okay. All right. Let's see. Last case. So last case is a mental health case. This is a person who has had depression on and off for most of their adult life, but right now has been a really hard time. They're basically incapable of even getting out of bed and getting to work. They're calling in sick for days at a time, then they'll go for 1 or 2 shifts, but they're not getting any of their charting done. Their charts are piling up. They're just really not functioning at a level that allows them to get their work done. So this person also can and should reach out to us. So for a person who's really significantly depressed or has anxiety disorder or PTSD or any mental health condition, what you need to know is it's okay to have a mental health condition and still practice medicine. You just need to take care of your mental health and get yourself into some sort of state where you can continue to work rather than ignoring the problem and letting it grow and grow. So the thing here is it's okay to get help. It's okay to have a diagnosis, and it's even okay to take mental health medications, SSRIs, SNRIs. The things that I would avoid would be things that are actively impairing, right? You need to not take benzodiazepines 3 times a day. Ketamine treatment is still very much up in the air for safety sensitive groups. We know it's helpful for depression in some groups, but for safety sensitive, we don't have the data yet for return to work parameters. Seeking care for your mental health will not affect your ability to be licensed. So typically, you might have to check a box on a form. I think they took the box off of the current licensing forms, but you might have to say like, yes, I have a diagnosis of major depressive disorder. Yes, I take escitalopram. No, it is not impairing. And, there might be a paragraph you have to write, but historically there were issues with this. Today, there really aren't issues related to the majority of mental health diagnoses. Now, if you are psychotic or have schizophrenia or something pretty significant, then yeah, you might need to really show that you're established with psychiatry and that your medication regimen is very dialed in and very closely observed by your treatment team. But in general, a mental health diagnosis is okay to have as long as you're taking care of it. And you can definitely call us if you need referrals to mental health providers, especially counselors and therapists can be very hard to find for health professionals because we are that weird special population. And a lot of times people are like, oh my gosh, you're so high functioning, you're fine. You don't need therapy. And you're like, well, I actually do. So finding people who are good and can challenge a mental health professional or a health professional can be very helpful, and we have a list of those resources. There's also a national crisis around physician suicide and health professional suicide. So please know the number 988. It's the suicide crisis line. Call it if you're ever feeling that terrible sense that you'd be better off dead. If you're interested in advocacy around this, the Dr. Lorna Breen Foundation is amazing. They're doing a lot of work to prevent physician suicide. I saw the founder or co-founder of that organization speak at our national conference, and it was just amazing. So they're doing lots of work around destigmatizing, changing medical licensure laws, etc. And yeah, great work is happening. But the take home here is mental health problems happen to everybody. It's not something that you're immune to just because you're in a caring field. And it's okay to get treatment for that. Just avoid things that are going to impair your ability to work safely, specifically the benzodiazepines. All right. So this is just a summary slide. It goes through those objectives and has little bits about, what we talked about. Basically, the last line is probably the most important on here. So when in doubt, you can always call us anonymously and run a scenario past. So say you've got a friend that you're worried about, you can be like, I don't know if this is the right person to refer, but can I just run this past you? And we can troubleshoot it together. How to do that? This slide has our phone number, has our website. Email is directed through Adam Varica. He's our executive director. He does all of our intake process. We are a huge company with 3 employees. So forgive us, sometimes it might take a few days. If something's really urgent, we will get back to you right away. If it's sort of like a, hey, I've got a question, it might be a few days before we get back to you. We also just recently created social media presence. So please follow us on Instagram, LinkedIn, etc. We would love to be connected to every health professional in the state so that as new people are coming in or new problems are arising, everybody already knows about us. And with that, we have 7 minutes left for any last questions, comments, concerns, feedback, anything. All right, let's see. What can health organizations do to advocate for the use of your organization? So, good question. What can health organizations do? So one of the things that they can do and that we've done with other organizations is actually have us give presentations like this or give grand rounds, give to come out to the hospital or the clinic and actually, bring a presentation or show up and do a table in the lobby or something so that folks can meet us and get to know us. Often we'll have 1 or 2 advocates at, or sort of, an ally is not the right word. Well, we'll call them advocates for lack of a better word. We'll have 1 or 2 people at an institution who know about us and sort of serve as the resource link. Often these are our graduates. So throughout the state, we have hundreds of people who have finished our program. And often they are the ones who either identify or create the bridge between someone new in the organization who's struggling and us. But I'm open to any ideas. When I started this job a few years ago, we really didn't have many connections around the state, so I'm trying to grow them as much as possible. All right, Zara Lucera. I think it'd be very helpful to have a more detailed talk about mental health do's and don'ts, as well as resources available in New Mexico for us as providers. So Zaira Lucero, could you, I don't know if you have your microphone or if you just want to elaborate in here, can you talk more about do's and don'ts? Because I'm not sure what I understand there. Maybe while you're doing that. Gabriela Morales says, do you think integrating this into medical curriculum could help? So that has been actually where I'm putting most of my outreach time lately. I've given 2 presentations to UNM Medical School, 1 presentation to the PA class, presentation to the Burrell Osteopathic School. I'm trying to get us integrated into every year of the medical training throughout the state, as well as the PA programs, the pharmacy programs, the dentistry programs, etc., so that people just know we exist and maybe have some resources earlier in their process. Okay, I'm not seeing anything else from Ms. Lucero. So detailed talk about mental health do's and don'ts and resources in New Mexico. I think that is excellent questions. I think we as a state are a little bit behind some of the other states in the country as far as taking care of our health professionals' mental health needs. Do's and don'ts, I think the do is going to be seeking help earlier. I think health professionals tend to delay taking care of themselves until they absolutely can't delay anymore. And in a state like New Mexico, where the wait lists are 12 to 15 months long to get in with certain providers, it doesn't work at that point. You delay until it's a crisis, and then there aren't really great crisis resources. Other states have done some interesting things around call centers, et cetera, or warm lines or hotlines just for health professionals. that I think would be amazing. I don't know if we have the resources as a state to pull that together very efficiently or in a way that would be sustainable. There's other programs out there that have started around the country around health professional suicide that I am hoping to bring to our program within the next year or two. Unfortunately, they're fee-based, and our program runs quite a bit on a shoestring budget, so we'll see if we're able to navigate that, but I'm hopeful. But definitely, if you want to have an offline conversation about that, let me know, and we can definitely talk more. All right. Well, thank you all very much. I think our time is just about up, so.